Hello, everyone, and a very warm welcome to everyone. Thank you for joining us for Arthritis Talks, Biologics, Biosimilars, and JAK inhibitors. I'm Dr. Sean Bevan, Chief Science Officer at Arthritis Society Canada. We've come together for this event from many different places, and I would like to first acknowledge the land on which I am located on and which our Toronto office stands, which is the traditional territories of the Mississauga of the Credit First Nation, Anishinaabe, Huron-Wendat, and Haudenosaunee Indigenous peoples. Today, this meeting place is home to many First Nations, Inuit, and Métis people, and I am very grateful to have the opportunity to live and work on this land. Now, biologics, biosimilars, and JAK inhibitors all have a purpose in treating inflammatory arthritis, but they are complex and they can be confusing to understand. So tonight, Dr. Alan Lowe is here to answer your questions and help provide clarity on these cutting-edge arthritis medications. So before we get started, just a few logistics. This webinar is best viewed on a laptop or desktop computer. If you have technical difficulties, please email arthritistalks@arthritis.ca for assistance. If you have a question for our presenter, you can submit it through the Q&A button at the bottom middle of the screen, not the chat, please. We will try to get to as many questions as possible during the hour that we have together. Now you can click on that chat icon in the bottom middle of the screen to access the chat and also connect with other participants, as well as our chat moderator. Now, if you do find that distracting and would like to close out of the chat completely, just click the red X icon at the window. We are also happy to continue to provide closed captioning of our webinars to accommodate the diverse needs of our audience. So you'll see that running along the bottom of the page. So many questions that we received in advance followed similar themes. So we'll look at those first before going into the live Q&A at the end of the session. And before we get started, I also want to thank our event partners, Pfizer, United Way Winnipeg, and others for their financial support of our Arthritis Talk series. So with that, let's get started, and a warm welcome to today's expert clinical pharmacist, Dr. Alan Lowe. So Dr. Alan Lowe, welcome. Could you first start by providing an overview of what are these medications that we're talking about, biologics, biosimilars, and JAK inhibitors, to help us understand?
Thank you, Sean, for that introduction and for this very pertinent question. And before I begin, I just want to acknowledge that I'm situated on the West Coast in Vancouver here in the unceded traditional territories of the Musqueam, Squamish, and Tsleil-Waututh nations. So getting back to the question here, what are biologics, biosimilars, and JAK inhibitors? They are certainly talk of the areas now in many immune diseases. So it's kind of apt to talk about the differences and some of the similarities between them. I'll begin with biologics. They're essentially a group of drugs that are generally or genetically engineered proteins, which are derived from animals or microorganisms. So these aren't synthetically produced. These are actually grown. So using a living system, often using DNA technology, these biologics are derived and are complex proteins. So they're very large molecules, and they aren't even identical from batch to batch when they're being manufactured. So they're used in many different immune conditions, and more are being added as these are being tested in clinical trials. These are very targeted molecules. That is, these are drugs that are engineered to bind to a very specific target, and oftentimes in the immune system called cytokines. So these are little substances that are secreted in our body to control our immune system and keep everything kind of in check. These drugs often require refrigeration to maintain a shelf life because, again, they are proteins. And you'll hear many of these names are very long, complicated names, and they oftentimes have the word MAB, or sorry, the MAB at the end of it, and that stands for monoclonal antibody. If we talk about biosimilars, they are also biologics, but they're the subsequent entry biologic that has demonstrated similarity to the originator. So we talk about the original or the first biologic of that molecule as either the originator or the reference biologic. But a biosimilar can be produced at a lower cost, and it's usually after the patent expires, of course, on the originator. And it does require the same chemical testing and the same clinical testing to show similarity. So these comparative analytical data that's collected, the comparative preclinical data and comparative clinical data are all highly similar without any statistical differences. All are branded molecules. So even though we're talking biosimilars that are a subsequent entry of the biologic, they each have their own trade name or brand name. So you'll have the originator or reference, and an example is a drug like Humira. Then we've got actually 8 biosimilars that are now available in Canada, and they have the names Abrelada, Amjevita, Hadlima, Julio, Hyrimoz, Idacio, Simlandi, and Euflyma. So all of these have their own name, but they all refer back to the chemical molecule adalimumab, and that's the chemical or the molecular name that's the same for all of these brand names. When your doctor prescribes the drug under that brand name, because they're biosimilars or biologics, it can't be interchanged. So even at the pharmacy level, pharmacists aren't moving from one version to another. They need to fill or dispense the one that's been prescribed. So although all the biosimilars are same molecules, they have slight differences, and we'll talk a little bit more about that later. But they have effects and side effects which are clinically indistinguishable from the originator. So to move on to JAK inhibitors, JAK actually stands for Janus kinase. And these inhibitors essentially block a certain part in the inside of a cell that's producing cytokines. And so essentially what it's doing is it's impairing the body's immune system. And that way it helps prevent that autoimmune effect where the body is attacking itself, preventing damage to the joints. And then of course, by preventing that, we'll reduce flares and reduce symptoms of the condition. The differences with these JAK inhibitors, they sometimes get confused and people may refer to them as biologics, but they aren't. They are small molecules. That is, they're chemically created or synthesized, and they're available as tablets or capsules. So these don't need to be stored in the refrigerator nor injected. They are oral or can be taken orally. And you can see in this diagram that these JAK receptors are inside of cells in many of these different cytokines. And you might have heard these terms before, like IL-6 that causes inflammation. We have IFN, which stands for interferon. They often are the innate immune responses we have. A number of other interleukins, which is what the IL stands for. And this is in our white cells, and they help with our immune system and how it reacts and how it's controlled. So with JAK inhibitors, they can access and impair, I guess, the normal function of many of these controlling mechanisms within our immune system. Just to expand a little bit more on the JAK inhibitors, they're used in many, many different conditions, some of which are official and have been approved by Health Canada, such as rheumatoid arthritis, axial spondyloarthritis, psoriatic arthritis, Crohn's disease, ulcerative colitis, atopic dermatitis, and also many other conditions are coming. And you might have even heard that some of these JAK inhibitors are used in the treatment of COVID infections. And that's also true. So some of these are off-label, so that is they are not officially approved by Health Canada, but there are demonstrated studies showing that they do work. A few of the names that are listed there you can see, and they have similar ending names with regards to the chemical. They all kind of end in this tinib kind of ending, which is kind of an indicator of a JAK inhibitor. So the first one out was Xeljanz, and then we've had many JAK inhibitors following: Symbico, Inrebic, Jakavi, Olumiant, Rinvoq. They're all available in Canada with different indications and uses. There has been a report associated with these, and particularly the early JAK inhibitors, with respect to heart problems, blood clots, and even some cancers. So there is some concerns, and a black box warning has been suggested by Health Canada, and that is people with a background history of certain cancers, cardiovascular risks, or even prone to blood clots, they should consider the other options first, and only with discussion with their healthcare professional should they really embark on using a JAK inhibitor. There's certain risk benefits that should be considered, and that's best discussed with your doctor, who knows your condition and also knows your background history of medical conditions. So just some final notes on the biologics, biosimilar, and JAK inhibitors. So these biologics, they are complex molecules used to treat a variety of diseases, usually immune-mediated. They are stored in refrigerators because they need to be kept cold to have a long shelf life. They are either injected under the skin or given by IV infusion because of their ability to be broken down if they're taken by mouth, by the stomach, and our digestive system. So they have to be parenterally administered. Biosimilars are the highly similar version of the reference biologic, and all the relevant structural and functional attributes, including safety and efficacy, are essentially highly similar and indistinguishable. The biologics and JAK inhibitors can be taken to treat many different conditions. And JAK inhibitors are a new category of drugs for use in conditions that involve autoimmune activity. So usually they're treated, it's unusual for them to be used in combination with a biologic and a biosimilar. So you're either on a JAK inhibitor or you're using a biologic or a biosimilar. Methotrexate, however, is something that is used in combination. And so you will see that there is sometimes a methotrexate continuing on as you start your JAK inhibitor, or if you're continuing on with your biologic or biosimilar.
Thank you, Dr. Lowe. That was really clear. So some of those originator biologic medications, they seem to have so many biosimilars. So could you help us understand how do they differ, and maybe importantly, how do you determine which will work best for you?
So before I get into, I guess, answering which is best and how to choose, let's just go into the manufacturing of the biologics. So as I was saying, biologics are essentially created through living organisms and living systems. So they essentially modify a host cell using DNA technology, and we grow these cells to actually produce these proteins. They're extracted, they're refolded, they're purified in a downstream process, and then they're formulated and stabilized into a vial or a syringe. And this is what's used for injection with the biologic. You can imagine that this kind of study in human studies to do clinical trials, as well as this manufacturing process, is rather complex. It takes a long time, and certainly growing a drug is certainly taking longer and more complicated than chemically synthesizing a chemical. So with that, we are seeing quite high costs. As a result, what we're seeing is these synthetic molecules that we started with, something like aspirin, which is a basic or a small molecule. This is the comparative size of it when we then consider and move on to a protein. So this is like an insulin, so recombinant type materials and drugs that are used to create insulin is a little bit larger. They are now moving to proteins, but not as complex as getting into a full-on biologic, which is a mammalian cell-derived glycoprotein molecule. So you can see that the relative size here being approximately 833 times bigger than your usual synthetic molecule like ASA, which is aspirin. And if you look at another way of comparing this, this is like looking at a bicycle compared to a car and getting into a biologic where we're talking about a full-on jet plane. So if you can kind of visualize that, we can then think about how do we go about making a duplicate or another derivative of that biologic molecule. And so generics are not possible. Generics are identical recreations of the original molecule. With such a complex molecule being the jet plane that it is, it's hard to create two that are equal. And I'll use another analogy to kind of help you appreciate it. So if we look at a tree that grows many apples, the same tree doesn't even produce identically tasting apples beside it, nor do they look identically alike, but they're essentially, would call them the same, coming from the same tree even. If we're looking at a biosimilar, we're trying to create a highly similar molecule. And with that, Health Canada has some requirements. They do have the identical amino acid sequence, so that's the primary structure. But as we get into the other structures, the secondary, the tertiary, and the quaternary structure, they're highly similar and not identical. And there's a number of chemical reasons why that occurs. The affinity, the selectivity, slight variations in pharmacokinetic profile as a result, the functional activity, solubility, and immunogenicity, they're all highly similar, but we can't say that they're 100% identical. The clinical relevance of these attributes that are slight difference don't seem to have any clinical impact. So based on Health Canada requirements, we're expecting the exact same clinical result with the biosimilar as we see with the biologic, the originator. Some originator medications have many biosimilars, some have only a few, but essentially what's happening is once an originator biologics patent expires, other manufacturers can come into the market and make their own version of the molecule. Sometimes possibly due to a large market, so many people using the medication, there will be many biosimilars out, and in other cases, there might be fewer. So with that, we have to recognize that there's going to be differences in its availability. There are going to be differences in the injection device that's being used. So although the drug itself is highly similar, we're going to see some other differences that you'll have to pick up on, such as the difference in the patient support program. Each one is individual, and they are all independent, so they don't communicate with each other. So if you were to move from one biologic to a biosimilar or from a biosimilar to another biosimilar, the patient support programs won't be communicating, and they really don't have an idea of what's happened in the past. And of course, the reason for these biosimilars is cost. We do know that the healthcare system is taxed, and we don't have essentially enough dollars in the budget to cover everyone the way we want to. And so these biosimilars do add savings. Oftentimes they're between 35 to 50% lower than the cost of the originator. And it's because fewer studies need to be done. Those initial research and development studies don't have to be recreated again and the cost put in. So biosimilars do have an advantage in avoiding some of those basic research studies that are needed to develop the molecule, and only need to do the clinical trials to show that they are similar or equivalent in its effects. When Health Canada approves a biosimilar, these are the kinds of things they look at. They look at the quality. So safety and efficacy of the biosimilar are highly similar to the reference biologic. If there's special authority or exceptional access in place, if it's approved for the reference, it will also be approved for the biosimilar. There are no clinically meaningful differences between the biosimilar and the reference biologic. The stringent practices by Health Canada for all approved drugs with respect to the good manufacturing processes and the controls that Health Canada puts in place are all applied, whether it's the originator or the biosimilar. And patients and healthcare professionals can have confidence in the quality, safety, and the efficacy, again, with the respective Health Canada keeping a close eye on this. It's possible to have different excipients within the biosimilar, that is, the preservatives or the stabilizers, and that can occur in the different biosimilar versions. So sometimes it's important to take a look at those excipients if that's really important to you, and you might have sensitivities. Just another way to look at this biosimilar is the development process. If we look at the generics, they are relatively quick to come to market, generally taking 2 to 3 years in development to create these. They're studied in between 20 to 50 patients, oftentimes are healthy volunteers. When we're looking at a biologic, it takes quite a long time for it to come to market. It's studied in many more people, of course, and many times there's also subsequent phase 4 trials that occur. With a biosimilar, it is shorter, but not that much shorter. As a comparison, between 7 to 8 years to develop that biosimilar. It has its comparative pharmacokinetics and phase 3 studies studied in fewer patients, but not as few as a generic. So you can see that there are some certainly differences, and it's not just a copy of the biologic. It's something that does have to be in some ways slightly recreated, and is, by avoiding some of the study costs, are lower in price. Which one is best is one of the questions, and that's going to be a hard one. Certainly that is very individualized to the patient. And I always suggest that there should be a shared informed decision-making process as you talk with your physician to see what suits you the best. But now that we have biosimilar versions available, you can look at the different size, shape, and how you hold that pen injector, if it's an injection pen that you're looking at. Sometimes it's the needle size that might vary slightly, the pressure needed to inject. These can all have slight variations, and finding one that suits you and how you can use it might help you decide what's the best for you. As I was mentioning, some of them have different excipients, so looking at the ingredients might also be a reason. And I'll just bring up the example of adalimumab. There are versions of this biosimilar that contain citrate, and some versions that are citrate-free. So if citrate is something that you're sensitive to or having a reaction to, finding one that is citrate-free is going to be beneficial. Costs are essentially equal among the biosimilars, so as they come out for the same molecule, they're all going to have the same price. But what can differ is the patient support program. So there's many different patient support programs, each associated with each product, but they might have different supports, such as providing different levels of financial assistance. Some might provide other benefits, such as paying for the costs of vaccines that aren't covered, or paying for certain lab tests that aren't covered. So these are individual things that are going to be supported by the support program or provided, and it may be different from province to province, since provinces have different levels of coverage, as well as for their vaccines and lab tests. Just keep in mind that regardless of whether you're taking a biologic or a biosimilar, you can always select the pharmacy that you prefer where you receive your medications and feel comfortable. The same goes for if you're receiving a biologic in an infusion clinic. You also have that ability to select whichever clinic that you'd like to go to. Not every clinic, of course, infuses every drug, so there might be some limited choices, but do know that you can ask for the different options that are out there. With respect to all the different versions, because there's supply shortages that have been occurring, delivery issues, supply chain issues, we are encountering some supply issues here and there that pop up. And sometimes that might dictate which is the best one to choose or which one is available at the time. So essentially, as a summary, the best one is the one that has the most suitable injector pen or syringe for you. It has compatible excipients. There's adequate financial coverage that's helped or supported by the patient support program. That patient support program is also suitable and comfortable for you to manage and deal with. And one more thing to note is some versions of these biosimilars have different storage times at room temperature. So it's possible that one might have a little bit longer storage, which means that if you're traveling, it can be out of the refrigerator and it's a little bit more convenient for you to have it out of the refrigerator for a longer time.
Thank you so much, Dr. Lowe. You covered a fair amount of pretty complex scientific information there, and I think that I hope that you've given people some good ideas about what to look out for and what questions to ask their healthcare providers going forward. Now, some patients are really quite concerned about transitioning to a biosimilar. So I know you'll share more, but what happens if the biosimilar doesn't work as well?
Thanks, John, for that question. And certainly across the country, we're seeing that many provinces are moving into a policy where people who are on originators or the reference biologic are needing to switch to biosimilar. And a lot of this, of course, is due to cost. And with a 35 to 50% reduction in cost, it's significant with these medications. But just to give you an idea of the background and what we're looking at with regards to this switch, clinical studies have demonstrated that the effects of the biosimilars are clinically equivalent to the originator. So in studies, as we're measuring it in patients with these conditions, we aren't seeing significantly different responses. The reasons to sometimes change back or have a conversation if there is an allergic reaction or a different effect. The difficulty with these different effects is that we are often treating a condition that kind of goes up and down. With respect to an allergic reaction, we can pay attention to, I guess, what's in the ingredients. With respect to excipients that are contained within the new biosimilar that you might be trying. Each might be a little bit different, but it is quite rare to have allergic reactions to the contents or the excipients of these drugs. Sometimes with the differences in effect, it could be narrowed down to the administration issues. So sometimes with these injector pens, if you're moved on to a new one, you may not be as familiar, and it might be the inappropriate injection that's not giving you the full dose that's causing a different effect. The other reasons in a infusion where you might be getting a different reaction or different response, it could be there's a different pre-treatment protocol because you've changed clinics. And sometimes that happens when you're changing from an originator to a biosimilar, that you've moved to a different infusion clinic because one didn't provide that, or you're moving to another one because of certain other reasons that biosimilar needs to be infused at a certain place. So after you have considered these other reasons of the biosimilar not working properly, as well as the disease fluctuation, and this is very hard to predict. You may know a little bit better as you speak with your doctor about this, but sometimes the lack of response, it's just a flare that was coincidental. It's not switching to the biosimilar, but it just happened at the same time when something came up. And you may want to take a look at, did your stress level change? Was there differences in your lifestyle that might have been associated with this rather than the biosimilar? You might be experiencing a nocebo effect. So this has become a relatively new and something that we do worry about because there's access to the internet, which sometimes gives very negative type connotations and perceptions that are out there. And what a nocebo effect is essentially experiencing a negative effect due to the belief. So not the reality, but the belief that the therapy is worse or it won't work. This is essentially opposite of a placebo effect. So the placebo effect is when you think it's going to work well, and even though it's a sugar pill, it's doing something, and that's because of a placebo effect that might be psychological or just built-in belief. So because of this perception that may be raised by people you talk to, by things that you read on the internet, it means that you do need to keep an open mind and look at the evidence and look at the data and not be swayed by just the hearsay type things. So speak to a licensed healthcare professional who's going to give you the evidence-based information, as well as your physicians and other licensed healthcare providers. You'll see that most payers that are out there, of course, have an interest in trying to reduce costs. So sometimes they're requiring an adequate trial of the biosimilar before allowing to switch back. So this means that it could take 3 to 6 months of trying this therapy before moving back. This won't be the case if it's a true allergic reaction. That's a recognition that it's not doing an adequate trial, that things will stabilize, or that it's a flare that needs to be controlled and dissipate. But if it's an allergic reaction, that's going to be more of a concern and a better reason to switch back. But most payers are going to have different requirements. Some even require using another biosimilar before going back to the originator biologic. Of course, a lot of this is cost-driven. And with these cost savings with these drugs, it is many things, or many times the payers require patients to look at this and having the doctors try a different biosimilar with you and then see what happens. It is important for you to document your response. So keeping notes of the reactions that you're getting, the responses, the dates and which biosimilar that you're using is going to help keep up the history and the details so that when you talk with your doctor, you can see what avenues and options might be available to you to potentially switch back if that's needed. And we're seeing that some physicians may be recommending that instead of switching back to the originator, that it might be time to move on to another biologic therapy. So it really, again, comes back to looking at your condition and your situation to see what's happening.
Okay, thank you, Dr. Lowe. So JAK inhibitors are being talked about more and more in rheumatology. So you touched on this previously, but how do they really differ then from biologics and their biosimilars?
Sure. So actually, there was just this one slide that I hadn't went over, but we did cover most of this information here. And I will just, sorry, a little bit slow on the slides there. We'll move over. So did I catch that right? So we're moving on to how are the JAK inhibitors different from biologics and biosimilars? And I think if we look at this table, it helps to illustrate it a little bit clearer and some of the aspects that might show some differences. So both biologics and JAK inhibitors are used in similar autoimmune conditions. JAK inhibitors actually, in fact, might have more uses that are being studied and are coming up more. But the biggest difference is between how it's administered. So administration of the JAK inhibitors is by oral tablets or capsules, so much easier to take, but they are also taken daily or twice daily. With regards to the biologics, they all have to be administered through a parenteral route. Parenteral meaning that it has to be under the skin as a subcutaneous injection or intravenous using an IV infusion. The dosing times with the IV infusions or parenteral can range anywhere from weekly to every 6 months. So you can see that the administration of those can be less frequent. Biologics were created first back in 1998 when it was first introduced into Canada, with JAK inhibitors coming in 2012. Both can be used with methotrexate, and oftentimes the two together work better than either of the one. So using it together is quite common. There's increased risk of infections with both of these. To say one causes more or less risk of infection is going to be hard to determine. It's really based on the individual, but both have certainly shown an increase in risk of infection. So anyone receiving either of these agents should be cautious with regards to, certainly during the flu season, so wearing a mask in crowded areas and in large gatherings and things like that is recommended. With respect to the cardiovascular risk, although biologics, of course, do have some rare side effects that can affect the heart, largely it's not something that we would go in detail to assess the cardiovascular risk before starting it. However, with a JAK inhibitor, that is something that should be done to see if there is a previous cardiovascular history, blood clot history, and that kind of thing before starting it, because of this association that was seen in studies. So although the number wasn't high, it was enough of an association to trigger a little bit of concern to be cautious, that if patients do have a background of cardiovascular risk, to avoid a JAK inhibitor if possible, and weigh the risks versus benefits before starting. As we talk about starting treatment, they can begin with either a biologic or a JAK inhibitor. There's certainly right now not clarity as to which one should be started first. There are some differences in the onset of effect. There are reports that JAK inhibitors do have a slightly faster onset of effect, so you can see differences or some impact on the symptoms within a few days to 2 weeks, whereas biologics often take several weeks to have an impact before you see something. However, both of them have a maximum or a peak effect in about 3 to 6 months, so there's not a big difference there. As you try to choose between these, it is speaking with your specialist, your physician, who again knows your medical history and your symptoms the best, and speak with them in a shared, informed decision-making way. That is, participate in that decision of which one to choose. It might be based on how you'd like to take it. So if oral capsules and tablets are a strong preference for you, even giving up a potential benefit in the control of the disease, but the convenience of oral tablets is better, then certainly that's something that you could speak with your physician about, and that could sway the decision. Infusions, of course, require you to go to a clinic, and that might be inconvenient with respect to having to go on a periodic basis to have these infusions and also have to fit in scheduling. And now with our shortage of healthcare professionals, oftentimes it's hard to find a good schedule that's going to meet your needs as well. With subcutaneous injections, however, it is something that you can do by yourself or a caregiver. And now there's many provinces where pharmacists are also able to inject the medication for you as well.
Thank you, Dr. Lowe. So you talked about this a few minutes ago related to costs. And as we know, medications to treat inflammatory arthritis can be very costly. So, what are some ways to find help in covering the cost of these medications?
Thanks, John, for that question. And absolutely, it's a big concern with regards to healthcare overall is the cost associated. As we look at the cost of these medications, biologics as well as JAK inhibitors can be quite costly, and not all of these medicines are publicly listed or covered. And so that means that sometimes it's relying on private plans to help cover this medication. So private health insurance sometimes will cover medicines that the publics don't. And of course, private health insurance is not all the same. There's many, many plans out there. So even employees who work at the same company sometimes have different plans. So it's something that you do have to look into. And if there's coverage, of course, that's going to help the out-of-pocket costs. Many of these medications, because of the high costs, require what's called prior authorization. That is a form needs to be completed by your physician or healthcare provider so that there is background and rationale as to why this medication is superior or more beneficial and also justifies the cost. This could be what you hear special authority in some provinces, exceptional access, or special authorization. And even some private payers require their own prior authorization forms to be filled. As you complete these forms, you'll see that there's a stepwise therapy that's often required so that it is the most cost-effective way to treat the condition, usually starting off with methotrexate plus other immunologic type medications to help treat it. So potentially using drugs like leflunomide or sulfasalazine and azathioprine, tacrolimus, sometimes cyclosporin, gold, and doxycycline first. Those are all medications that, of course, are less costly than biologics and JAK inhibitors. And if they work with few side effects, then that is a good medication for treating you for that condition. However, if these don't cover off all the symptoms and reduce the flares and relapses as it should, that's when filling out the special authority forms moves you to the next step. You'd have to check with your own provincial public plan to see which one is the one that, or which drugs are covered. It varies depending on your province, and some provinces even require other qualifiers, such as completing your income tax in BC before a special authority can be granted. Check with your, or sorry, not before a special authority should be granted, but it applies to it where the Fair Pharmacare deductible is what applies when special authority is in place. So they do require income tax to be completed. With regards to private plans, you'll also have to check about the individual coverage and what steps are needed to access the coverage. Don't forget that if you have a spouse with a plan, there's also coverage through that route. And then watch for yearly limits and lifetime limits, because sometimes these private health plans have a certain amount that can be spent per year and a certain amount that could be spent over a lifetime, which means that as you use a more costly medication, it's going to start to use up that limit faster. So it actually makes sense also for the average person with a private plan to try to use the lowest cost medication that does work for them. You'd want to discuss the options with your physician. And if this is the first time you're going on to a medication or a biologic, it might be useful to even identify a few so that you can do some investigation or research into it to find out which one has the lowest net out-of-pocket cost that's the lowest for you. And your pharmacist might be able to help. Many of them have what's called online and real-time adjudication. That is, they can submit and see how much it's going to cost. However, sometimes you have to get the paperwork all done before you know what it's going to be like. And pharmacists oftentimes have an idea of how much support can be expected from a plan or from a patient support program. Patient support programs also need some paperwork completed through an enrollment form to get set up on their system, and will oftentimes offer financial support for those that are low income. It's oftentimes based on need, and it's individualized to the patient's need. So there are times where the financial support can vary, as it does with BC's Fair Pharmacare program, also based on income with a higher deductible for those with higher family incomes. So there are going to be different patient support programs because of the different products. And because of the different, options that are available is where your pharmacist can potentially speak with you and give you a better idea of what might be the out-of-pocket costs. You can also speak with the patient support program directly. They're also able to speak with you and give you an idea of what kind of financial support they can provide. With regards to private plans, you can call in to ask about your deductible, find out about your maximum limits, whether you have any per year, or whether it is a lifetime maximum for how much can be spent on drugs. And of course, depending on the province, there are also these patient assistance cards, which are copay cards that help pay some of these deductibles. And again, you can speak with your pharmacist about those. And if they're familiar with these different kinds of therapies, they'll be familiar with whether there is such a copay card that's available for these medications.
Okay. So the next one here is a very specific question, but it just came up so many times in emails before the webinar. We wanted to just address it up front. So the question really is about rituximab, which has some challenging side effects. So could you speak to other options that people might be able to consider?
Sure, I can certainly appreciate that question. Rituximab is a little bit different from the other biologics in that it does have this B cell effect. So specifically, and a little bit technical here, is that rituximab is a biologic that binds to the antigen CD20. That's a human B lymphocyte restricted differentiation antigen, often abbreviated BP35. It's located on B cells, and essentially rituximab can deplete the circulating B cells. And you can think of a B cell as a white cell or a cell in the immune system. And currently, there's no other drug that targets the B cells quite the same way. And so we are looking at mainly rituximab as use in that. Now, rituximab does cause an impact on our immune system such that we see more infections, as well as during the infusion, there seems to be more reactions as well with this particular drug. So that combination sometimes makes it hard for people to take. And there are some steps that we can take to reduce some of these side effects and these negative effects. Certainly with regards to infection, and this applies to all of the biologics and JAK inhibitors included that affect our immune system, is to be careful to avoid anyone who is contagious or is in that infectious state. And during flu season, if you're hearing people coughing, etc., is certainly to avoid, and wear a mask as well. And also hand washing and good hygiene in that way to help prevent infections is very important. With regards to that rituximab infusion, some people do have these reactions, but studies and experience have found certain ways that help to reduce some of these infusion-related side effects. That is, taking acetaminophen or Tylenol can be taken before the infusion, about half an hour, and also take another dose 4 hours into the infusion to continue the effect. This infusion can be done over a longer period of time. So if you slow it down, that can also reduce the reactions to the infusion. Sometimes taking a pause. So pausing the infusion, then restarting it slowly and getting it back up to the same rate will also help. Over time, these folks that are getting some of these infusion reactions, it tends to disappear. So it may be just a bit of time to get over that first few steps of your body getting used to it. And whether it's a slower infusion using the pre-treatments, sometimes using a corticosteroid called methylprednisolone also helps. Diphenhydramine, which is Benadryl, can also help to reduce these infusion type reactions. And sometimes during the infusion, doses of hydrocortisone or additional doses of Benadryl or diphenhydramine are also given to, again, take control of these infusion type reactions so they aren't as severe and the symptoms are moderated. There are other B-cell drugs out there, not currently used in rheumatoid arthritis, but there is one that's a slightly different mechanism, doesn't exactly bind to the CD20 as rituximab does, but it is binding to the B lymphocyte stimulator, abbreviated BLyS. And what it does is it inhibits the survival of these B cells. Currently, it's only approved for use in systemic lupus and also in active lupus nephritis. And there are other B-cell agents that are coming out, some of which are being used in multiple sclerosis and, again, are affecting the B cells in a different way. So we are beginning to see more in other indications and uses. Research, of course, continues to look for other agents that use the B-cell mechanism, but one side effect we won't be able to get away from is that risk of infection. So as we modulate the immune system to prevent an autoimmune effect, we're also going to slow down our immune system in protecting us against infections.
Okay. So we've certainly had many questions along these lines tonight already, and it really relates to how to find accurate and easy to digest information about medications. I'll get to some of them in the Q&A about how you would classify certain drugs with respect to what we're talking about tonight. But do you have any recommendations for our audience?
So with regards to more information, certainly the Arthritis Society website is one of the first go-to places to capture information. I do want to caution everyone to be very careful as you read and look for information on the internet to make sure that it is coming from a reliable source. There are just so many internet sites nowadays that are out there for promotional and marketing reasons where they're trying to sell you something or trying to promote something, and it's not necessarily evidence-based type information and not necessarily credible. So certainly see who is the source of the information, and the credibility of the provider comes into play. Canadian sources are certainly preferred, but obviously these drugs and the conditions are going to be the same, whether in this country or in the US and others. So you might find other sources of information, but the ones that are developed by licensed healthcare professionals, those that have advisory boards and scientific advisory boards that are made up of licensed professionals are also going to be more dependable. The reason I keep using that term licensed healthcare professional is that they are regulated. That means those healthcare providers can't mislead you without getting into trouble. They could lose their license, they can get into other issues and reprimands as a result that would affect their practice. So someone who's unregulated can really say anything, and there's really little or if any repercussions. And so that's why we do have to be careful of who the source is of information and what you want to believe and work on. I've listed a few of the folks here, your pharmacists, your rheumatology nurse and rheumatologists within this area of conditions are very reliable sources of information. They're all licensed professionals with regulatory bodies, with colleges that ensures that what they're providing and that they have an ethical responsibility to care for patients. I've mentioned, and you're here because of the Arthritis Society of Canada, but there's also the Canadian Arthritis Patient Alliance or Arthritis Research Canada. Another source is RheumInfo, developed by a group of healthcare providers that has patient-oriented information so that you can look up side effects and uses of medications. And there's also patient support programs that you might speak to if you're on one of these products. Do remember that a patient support program can only speak to one product provided by one manufacturer. So they're not essentially your healthcare provider because they're limited in not being able to speak to your other conditions or your other drugs. But certainly with the medication that you're working on with that patient support program, they can be a good resource and provide good information.
Okay, so before we get into some more Q&A, do you have any final thoughts or recommendations that you'd like to share for our viewers?
Yeah, but I guess one thing is that I just want to thank everyone for coming and actually listening and learning more about the medications. I want to emphasize that for each individual, that the best resource and taking care of yourself is yourself. No one's going to take better care of yourself than yourself. And nowadays, with so much information out there, navigation is the important part. And so for you signing up to this webinar, getting some additional information to know how to help yourself, how to navigate the more complex healthcare system, access healthcare providers, and do let them help you. And, look at different options as well. That's the other thing that I'd like to encourage, is to see what other options you have with respect to, it could be diet, exercise, medications, but there's usually more than just one, because if that one option doesn't suit you perfectly, maybe another one will, and it's always a balance of risk and benefit. So it's not always necessarily the best, most powerful medication is for you. If you can't go in to get an IV on a weekly basis, that's just unreasonable for you to do, then that medication is not going to work well for you either. So lots of those kinds of decisions go into play as you try to navigate what's the best for you.
That's great. Yeah, that makes a lot of sense. Okay, so we have lots of great questions. Let's see how many we can get through.
Okay.
The first question here, for clarity, is a biosimilar the same as a generic? And if not, can you help people understand what the differences are?
Okay, so I talked a little bit about it, but I'm going to expand a little bit more detail. So a biosimilar is tested in patients with the condition, and the drug is created to be highly similar to the original molecule. So they're not identical, and it's impossible to make it identical. Even the originator, as they create a batch of the drug to the next batch, they aren't identical. They can use the same recipe, they can do everything the same, but it won't be 100% identical. And that will be an analogy that I'll use as like baking a cake. You can use the same recipe, but it won't be exactly the same as the last cake that you made. It may taste slightly different. The texture is a little bit different. I go back to the analogy of the apple tree. 2, 3 apples off of the same tree look a little bit different. And that is the same tree that it came from. Because as we're talking about natural protein type substances and things like that are naturally created, we can't make them identical. Now, this is completely different from a generic. A generic version of a drug is usually of a small molecule, which you can identically copy and synthesize exactly the same. The molecular structure is 100% the same. It is the same chemical. So generics can come out a lot quicker because we can make that identical copy. And because they are identical, Health Canada requirements do not require testing in patients to see if the drug works. Because it's an identical drug, the assumption is that it will work. And the only testing that's required is that the generic has to have the same absorption and pharmacokinetic characteristics as the original. And what is pharmacokinetic characteristics? That is, we want to see that the same blood level is produced with the generic as it is with the original drug. And so if you're getting the same blood levels, it would be assumed that you're going to get the same effect. And so with an identical molecule, you can see that it is much easier, and there's interchangeability. So when a prescriber prescribes a generic or a drug that has a generic, the pharmacist can choose from the multiple generic makers as to which one to use. And you might have seen this when you've gone to the pharmacy. You'll be on the same drug, but the color of the pill is a little bit different, or it's a different shape, and it's because it's made by a different company, still the same chemical or molecule. You won't have that happening with regards to biosimilar. If you're on one biosimilar and that is prescribed, you will get the same biosimilar version when you go back in. So you shouldn't have a different color pen. You shouldn't have a different pen. It will be the same one that you get each time. And because the pharmacists today in Canada can't interchange from one to the other, they do dispense what the prescriber has prescribed, unless they gave the chemical name. If it's prescribed as adalimumab, then there are 8 different versions the pharmacist can choose in discussion with you on deciding which one might be the best to fill it with you. You won't have that discussion with a generic because they're deemed to be so identical that there's not a reason or a rationale or requirement to speak with you about choosing which generic company to use which drug for you.
Okay. And again, for clarity, there are other drugs that people are very familiar with that they're on for their inflammatory arthritis, methotrexate, hydroxychloroquine, for example. So where do they fit in relative to the categories of drugs that you've talked about tonight?
Right. So those drugs that are more common or that you hear more of, and some that I listed before, are usually used at the beginning. Oftentimes, they are the lower cost versions of medications, and it's using that stepwise approach of going with the lowest cost, sometimes most familiar medications. Methotrexate has an abundance of studies in patients that have been studied on that medication in the past. And so it is often the first go-to in immune type diseases. And it also has a comparatively low cost, certainly compared to the biologics and JAK inhibitors. So as a result, we're seeing a huge, I guess, incentive to start with methotrexate first. But I guess if we were in a world where cost of drugs really didn't matter, if everything was equal and you can be on any drug at all, we would probably have a predilection to go with a biologic or a biosimilar or a JAK inhibitor first. It is more costly, but in some respects, we've seen higher efficacy from some of these medications and also a lower level of side effects. But because of the costs, and if someone can start on methotrexate, get a good response, have few side effects, we're actually then ahead of the game, getting a medication that is not very costly, that works well. The other thing is methotrexate's a good adjunct, as well as hydroxychloroquine and others. So they are used in combination. And we'll see that there is sometimes using the two together is better than any of the one, but not only that, but they're synergistic. So synergistic meaning you use 1 + 1 and it equals 3. So you're just getting an overall better impact by using the combination of that. And it may allow you to get away with a lower dose of methotrexate. And if that happens, it means less methotrexate type side effects or none. And having the efficacy of the methotrexate together with the benefits also of a biologic or a JAK inhibitor. So in that case, we're doing very well in controlling the condition.
Right. So methotrexate isn't actually any of those categories, right, that you were talking about earlier.
It's not. It is a small molecule, not a biologic, and still, of course, affects the immune system and also has, I guess, multiple areas in the immune system that it affects.
Okay, great. Could you talk a bit about some of the risks and side effects of taking some of these biosimilars?
Certainly. With regards to biosimilars, biologics, or JAK inhibitors, the side effect profile is going to be slightly different, but similar in many cases, and is very individual to the person. So you can imagine that someone who is 80 taking this medication versus 18, we're going to see very different profile of side effects. And I know that if you read something, you're going to get a big list of side effects. And unfortunately, in monographs, they do have to list every side effect that has been reported with clinical trials. And so sometimes it could have even been coincidence or happened very rarely, and it still needs to get listed because it happened one frequent more time than it happened with the sugar pill or the placebo, and it needs to be identified. And so that's how we end up with these big, long lists. But it's better if you can talk with your healthcare professional to find out what is tailored to you and what side effects, based on your condition, your age, and your background and history, what side effects you can expect. But in general, these immune modulating drugs all going to increase the risk of infection. So that's one thing that's consistent with them all, because that's how they work. They are going to reduce our immune response so that we don't have an autoimmune effect. That is, your body doesn't attack itself, but then it's also not attacking foreign bodies, such as infectious organisms, that also might cause an infection. At the same time, JAK inhibitors do have that additional association with some of these cardiovascular risk factors, with cancers and with potential blood clots. So in that respect, we're seeing some differences as we get into these JAK inhibitors. There are going to be some less common effects that we see from biologics, and sometimes they can affect the central nervous system. So there are reports of vision changes, numbness and tingling, because it's affecting nerves. There are also some uncommon reactions that are related to the heart as well, where people feel some shortness of breath, sudden onset of heart failure if they have heart failure. With some people who have some breathing respiratory issues, might have some difficulty breathing with conditions such as COPD. Others may have rashes and different responses because it's a foreign drug that's in the body causing a reaction to the skin. These are certainly less common, but if you're going to go down the list of side effects, these are a little bit more common than the really, really unusual rare ones. And anytime you're starting a new medication, be on the lookout for anything that's new and not usual for you. And the ones that you have to see the doctor about is anything affecting the heart. So if you're getting heart-related symptoms, breathing-related symptoms, that needs to get looked at immediately. And be careful of infections, so that if you are having something come on, to have little bit of a lower threshold or a lot lower threshold, to go have that assessed to see if you need an antibiotic to get that treated, or what you might need to do if it's a viral infection, because antibiotics aren't going to work and you'll need to do something to help speed up your body's recovery of that viral infection. In some cases, it might even be stopping that immune modulating drug you're on for a period of time for yourself to recover. Just depends on the person themselves to see what's happening.
Okay, great. There's a question here about why are there so many biologics, biosimilars, JAK inhibitors? Does that mean that some of them just don't work?
So, of course, every person is very unique. And we were talking about how very specific and targeted these molecules are. So part of it is because we have individual responses, and our immune system is so unique in such a way that we're looking for that perfect match to find the biologic that's going to attack that cell that is causing the most problems. So then we are coming up with new and more chemicals to attack in that way, always trying to strive for the efficacy and reducing side effects to minimal possible. And each person responds differently. The other reason for it, and this is because these drugs are proteins, so these biologics are very large molecules, and our body can see them as a foreign body, and as a result might attack it and make it not work anymore. So we will have these things, and you'll have heard this term anti-drug antibody, and it's exactly as it sounds. Our body is attacking the drug, it's making it ineffective, and so it stops working. And for some folks, after having been on these medications or treatments for many years, they're finding diminishing effect because of this anti-drug antibody effect, which means that we have to come up with a new drug that's different enough that will have the same or similar effect, same mechanism, but be a different shape so that anti-drug antibody won't attack it, kill it off, and make it ineffective. So it's not that the drugs themselves don't or start off ineffective. It's because sometimes your body is going to attack it and it won't be effective for you anymore, as well as each person is individual. And this is why we run into the situation of sometimes cycling, of using one drug, didn't work so well, or too many side effects, and then we go to the next. And everyone being individual makes it difficult to choose. There are some ways now to help reduce that long list of options to what might be best for you, and that is pharmacogenomic testing. So by measuring your DNA, there's some tests that are out there that will, according to your DNA, help to identify some of the drugs that work better or the best for you, and some drugs which might be a problem because of your genetics. And so that might shorten that list of options to choose from. So again, it comes down to us all being individual.
That's great, Dr. Lowe. I'm going to end on one very timely question, and that is around vaccines. So the question is, are there any concerns with these biologic medications and how they relate to the efficacy of things like the COVID vaccine or RSV vaccines, et cetera?
So the connection between vaccines and these treatments, of course, vaccines utilize our immune system to work. So what a vaccine normally does is it introduces the antigen, or what your body's supposed to attack. And it's essentially a training exercise for your body to recognize what a virus or what a bacteria is going to look like, so that it's ready for the real thing. So the vaccine won't give you the infection, but it kind of tricks your body into thinking that it is, helps it build an immune response. And then that way, if a real infection comes along, it's controlled right away. With using drugs that affect our immune system, obviously that training exercise won't work as well, because our immune system isn't at its best. We're purposely using drugs to slow down the immune system so it doesn't attack our joints or attack our tissues, etc. But at the same time, it's not going to build up a response to vaccine. So in some cases, we'll try to time some of these biologic treatments. So for instance, if someone is on rituximab, which is one that blunts a response to the vaccine quite dramatically, we try to time giving the vaccine towards the end of the rituximab cycle. So that way, the rituximab effects are beginning to wear off. You haven't had the next dose yet, and your body's most ready to respond to the vaccine. And we want to give the body 2 to 4 weeks to build up and build that antibody response to do that training exercise. So there are times where we'll time the administration of the drug to make the most of getting a vaccine. And if you talk with your healthcare professional, with your pharmacist about it, you can time it to when you're getting your flu shot, your COVID booster, your RSV. Those that are taking immune modulating drugs are recommended, and the NACI guidelines are encouraged to take a vaccine to cover off as much as you can. So that is every publicly funded vaccine you certainly should get a hold of. And then there's a handful of non-publicly covered vaccines that you may also want to consider. And I would recommend that each of those patients on immunomodulating drugs do get those vaccines. And so that could be RSV. That is a new one out. It's only been out for a few months. And of course, many of the plans haven't covered it yet. But it is, so far as we know, it is a one-time kind of treatment. It should not be the recurrent as we see with COVID or flu. Also, shingles vaccine is very important because as we suppress our immune system, those of us that have ever had chickenpox as a child or earlier, shingles is a flare of that same virus. So it's varicella zoster that is coming out. And as a result, shingles is devastating. And there is a shingles vaccine out there. So Shingrix is a vaccine that helps to curb shingles. In fact, it has an efficacy rate that's above 90%, so it's really good at it. And we've seen that JAK inhibitors actually have a slightly higher risk of causing an outbreak of shingles compared to the other biologics. And we've been seeing some of those numbers, and you'll see that many prescribers, before they actually start the JAK inhibitor, will recommend that you get the shingles vaccine before starting the JAK inhibitor. Again, giving the shingles vaccine time to work. Shingles vaccine is a 2-injection vaccine where you do one and the next one is in 2 to 6 months. And so 4 weeks after your last injection is the earliest that you'd want to start a JAK inhibitor or a biologic so that you can give the vaccine time or your body time to respond to the vaccine. So vaccines, absolutely important. Get all of them that you need. Every year, get a flu shot. And for those that are seniors, the Fluzone high dose, which is the only high dose one that's out there today, is also recommended. Unfortunately, not every province covers it, but some provinces do. And so if you're elderly, the high dose is certainly a good recommendation if you're on immunomodulating drugs.
Okay, wonderful, Dr. Lowe. So thank you again so much for sharing your knowledge with us today. We would like to take just a few moments to get the audience's feedback on the presentation. So for those of you watching on Zoom, you'll see a poll question pop up on your screen. So do click on the answer that reflects your thoughts. And the question is about, do you feel more knowledgeable and empowered after attending this webinar? We will also be sending you an evaluation form when we email the recording and the slides. So if you weren't able to access that poll question, you'll have the opportunity to give us feedback then. And we use the survey feedback to really shape our Arthritis Talks series. So thank you in advance for your input. Once again, we are grateful to Pfizer, United Way Winnipeg, and others for their financial support of this event. And advances in treatment for arthritis would just not be possible without the support of our community. And with Giving Tuesday just around the corner, we do invite you to support critical research and life-changing programs to create a pain-free future. So all donations to Arthritis Society Canada received until November 28th will be matched. So you can make a donation on our website at arthritis.ca if you are able to. We will be back again on December 13th for Arthritis Talks, Unlocking Physical Activity with Assistive Devices. More information and a link to register will be included in the email to you tomorrow. So this does conclude Arthritis Talks. On behalf of all of us, thank you so much for joining us today, and do stay well.